My name is Ruth Wychuck, and I'm the Professional Practice Lead at the Care Center for Internationally Educated Nurses. I would like to start today by honoring the land that we are on, which has been the site of human activity since time immemorial. It is the traditional territories of the Huron-Wendat, Anishinaabe, the Chippewa, the Haudenosaunee Confederacy, and most recently, the Mississaugas of the Credit First Nations. Ontario is covered by 46 treaties and other agreements and is home to many Indigenous nations from across Turtle Island. Excuse me. Pardon me, just have a dry throat. Sorry. These treaties and other agreements, including the One Dish and One Spoon Wampum Belt Covenant, are agreements to peaceably share and care for the land and its resources. Other Indigenous nations, Europeans and newcomers, were invited into this covenant in the spirit of respect, peace, and friendship. We are all treaty people. Many of us have come here as settlers, immigrants, newcomers in this generation or generations past. We also acknowledge those of us who came here involuntarily as part of the transatlantic slave trade and honor and pay tribute to the ancestors of African origin and descent. We are mindful of broken covenants and we strive to make this right with the land and with each other.
Okay, so my name is Vanessa Weeda, and I am a registered practical nurse. I'm working here in Ontario in long-term care, and I'm also a Bachelor of Science in Nursing student. And I'm in my, I guess I can say, final days now of my degree, and I've been lucky enough to have my final placement with Care Center. And today I'm going to be presenting on long-term care, specifically here in Ontario. And as many of you I'm sure know, some of you might not, but we could talk for hours and hours about long-term care and really could go into a lot of detail. But for today, I'm just kind of going to highlight here on the agenda, what is long-term care, who lives in long-term care, how is long-term care regulated, how is long-term care funded, who works and with long-term care, who works in and with long-term care. And I'll highlight kind of what a day in the life of me working in long-term care is like. Of course, that can vary from nurse to nurse and facility to facility, but I thought it'd be interesting to kind of, for those that are unfamiliar with long-term care, as to what it looks like, and as well as responsibilities of registered staff, challenges of working in long-term care, and why one should work in long-term care, and what is so great about working in long-term care. And lastly, I'll touch on some future opportunities that can come from working in long-term care. And before I get into it, I just wanted to touch on a couple of housekeeping items. So if everyone can please stay muted, as you all already are, for the presentation. And if you have any questions, feel free to type it into the chat box, and those will be addressed at the end of the presentation. And as I work my way through, as we all know, this is a part of Care Center's 20th anniversary celebration of success. And I wanted to highlight Care Center's values before we get started. So those values are respect, honesty, accountability, professionalism, confidentiality, teamwork, and compassion. And as I'm sure you'll all notice, that as I work my way through of what it is to work in long-term care, that not only do these values align with long-term care, but they really are the root of the nursing profession. And I'm sure that's why Care chose that as their values. So let's get started. So what is long-term care? So according to the Ministry of Health and long-term care homes are where adults can live and receive 24-hour nursing, personal care, and help with their daily activities. These homes are also called nursing homes, municipal homes for the aged, or charitable homes. On this next slide here, I've pulled a few pictures to show you kind of what it could look like in some nursing homes or long-term care homes. It doesn't quite look the same as a acute setting in a hospital, and it's not supposed to. These are the individuals or the residents' homes. And so as you can see in that top right photo, there's pictures on the wall of loved ones, friends, family. You can see their personal furniture in the room and other personal items. And so that's really important because I'm sure any one of us would also want to have our personal belongings that we hold near and dear to our heart close by in our home, as we do now, right? So it makes sense that they have that too. And as for the actual facilities, they can really vary from, 7-story buildings, kind of like you see in that one photo at the bottom there, and more kind of ranch style or lower rise buildings. So it really varies from, area to area and home to home, what they look like. So here in Ontario, we have 626 licensed homes, which are approved to operate. And of those homes, 58% of them are privately owned. 24% are nonprofit or charitable homes, and 16% are municipal or public homes. And within these homes, there's a varying range of types of care that is provided. As it states in the name, of course, there's long-term care. And that's, of course, the biggest population within the homes. And so typically, those are individuals that are admitted in later stage of dementia, where their family's no longer able to care for them. So they've maybe lived with their children or grandchildren for some time, but it's become unmanageable in their residence, and they need a little bit more assistance, and they just may not have the resources at home for the care that they need. There's also convalescent care. So these are individuals that might require assistance with their activities of daily living. So that's ADLs, post-op. So after having perhaps a hip replacement, knee replacement, and typically before they were independent, able to even live on their own or maybe live with family members or a loved one. But because they're still recovering from their operation, they need still a little bit of help to live safely and be able to complete their activities of daily living. So typically they'll stay in a long-term care home from anywhere from 30 to up to 90 days in convalescent care. And also there's respite care. And so that is to provide caregivers. So an example I'd give is, say, grandma is living with her daughter and grandchildren, and she's no longer able to, say, fly, and the family wants to go on a little holiday over March break, when we were able to go on holidays before COVID, and grandma can't come, unfortunately. So but they want grandma to be well taken care of, so they put grandma in respite care, and so they have a temporary break from their role as caregivers, and therefore in the long-term care home there'd be some designated beds for respite stay. And that's just one example. Of course, there's many different reasons why someone might stay in respite care. And additionally, there is restorative care. So that's with the intent of improving ability to cope and perform with activities of daily living with less assistance. So these individuals are hoping to improve and eventually possibly move back to living more independently. And some types of care or individualized kind of programs that might also exist within long-term care are, say, palliative or end-of-life care, which some homes might have designated units for that or designated beds, or they might adapt as needed sort of thing. Also, I had interviewed with a few clients of care through a podcast, which I will happily share the link to at the end of the presentation. But one of the nurses I interviewed, Chris, who has a lot of experience as a nurse and specifically in long-term care, he mentioned that at his home here in Toronto, he is working on a team that deals with MAID, so medical assistance in dying. So that's also a different program of care and aspect of long-term care that might be in place at some homes. And it's new, so there's still, the future might grow and grow, and we don't know. So next, on to who lives in long-term care. So lots of individuals, and I kind of caught myself when I was actually starting with this slide, and I don't know if it's because I'm preparing for the NCLEX exam or what it is, but my mind is very medical focused right now. And I started off with saying, oh, older adults with dementia and this, and then I stopped and I took a step back, because that's not just who's living in long-term care. We have mothers, we have fathers, husbands, wives, daughters, sons, brothers, sisters, aunts, uncles, cousins, friends. These are individuals, and they're more, and we emphasize this all the time in nursing and of course in education, that they're more than their illness. And that couldn't be more true. I don't know if that, I can even say that in long-term care, because this is their home. And it's a really diverse group of individuals from all walks of life. You meet all different sorts of individuals with so much experience. You can only imagine that when a resident has 100, 101 years old, you know, what experiences they've had in their life. And it's quite special to be able to work alongside those individuals. But so from a more medical perspective, the typical population in long-term care are adults 65 years and up who require moderate to extensive assistance with their activities of daily living. And yes, many are diagnosed with dementia or other cognitive impairments. Atypical population, so kind of the minority of people that are in long-term care are post-operative adults, as I had mentioned. So maybe they had their hip replaced or the knee replaced, and they're unable to return home just because they have some limitations, some physical limitations from a recent surgery. And also young adults, so 18 years and older, who require as well moderate to extensive assistance with ADLs due to maybe congenital health conditions or whatever, traumatic injuries. And so I know, for instance, at my workplace, we have a separate unit, a young adult unit that is designated to individuals kind of under 55 or under 65 even, so that they can hang out with each other and other people kind of closer to their age, which is great. And in long-term care here in Ontario, we support 115,000 people and their families on an annual basis. Yeah. So again, kind of more medical side of things, that these individuals do often have many comorbidities, and there can be some complex health conditions. So 90% have some form of cognitive impairment, 80% have neurological diseases, 76% have heart and circulation diseases, and 40% need monitoring for an acute medical condition. So it can be complex, and you know, every unit's kind of different. I know that, for instance, where I'm working on my unit, we do have a younger population, and these individuals are still actively attending appointments and hospitals and really dealing with kind of acute medical conditions. And so it's not just maybe a stereotypical perspective on the elderly and that they're at the end of their life. Like some of these people still have a good chunk of life to live, and we're there to support them in that journey. So how is long-term care regulated? So it's all, like I had mentioned, all homes are licensed by the Ministry of Health and Long-Term Care. So that's a provincial governing body. And then government agencies, so like LIN, which is the Local Health Integration Network, determines the eligibility and manages the wait list for long-term care. Each home is required to follow the Long-Term Care Act, which is a very strict legislative piece. And within that Long-Term Care Act is the Residents' Bill of Rights. And so on a daily basis, when I go into work, we have the Residents' Bill of Rights. It's there posted, and it's a very important part of everyday work in long-term care. And so what it consists of is 27 statements, which have been put in place to ensure that the residents receive safe, consistent, and high-quality resident-centered care, where they can feel at home and that they're being treated with respect, and that they have the supports and services they need for their health and well-being. So as a few examples here for some statements that you can find in the Residents' Bill of Rights is every resident has the right to be protected from abuse. Every resident has the right to have his or her participation in decision-making respected. And every resident has the right to meet privately with his or her spouse or another person in a room that assures privacy. And so you can kind of understand that it is very much the focus of long-term care is the residents, and everything that we do, everybody, whether it's nursing staff, housekeeping, anything, the center of the home is the resident, and that is what needs to be emphasized, and that is exactly what the Bill of Rights for the residents fights for and represents. So for some people, it might not be obvious that funding is partially by the Ministry of Health and Long-Term Care, so by the municipal government. And then residents also do pay a fee for their accommodation. So the provincial government, their funding covers the cost of staff and supplies that are related to nursing and personal care, as well as resident social and recreational programs and support services. And also the government funding provides the raw food, kind of the funding for raw food to make meals. And then the residents pay for non-care staff, utilities, mortgages, building maintenance, and kind of other major capital repairs that might incur in a facility. And so the cost of the residents may pay can range anywhere from $1,850 to $2,640 a month. This obviously can vary depending on the type of home. So whether it's a newer home, older home, whether they're in a shared room, like semi-private room, or in a 4-person room. But these rates are set by the government, and the government provides subsidies as needed for the residents, because they do want people to be able to access and afford safe care. And also it's important to note that, as I mentioned, there's kind of 3 major sectors of long-term care, but all sectors, the funding and profits are all presented publicly, in which the homes present in their final report of every year, and it's reviewed by the government just to ensure that everything is being followed. And this is something that's also embedded into the Long-Term Care Act, and so to really ensure safety in care. The next slide here, I have just an idea of kind of what it would cost on a daily basis, depending on the type of accommodation. So a basic room would be most likely a 4-person room, semi-private, so 2 people in the room, and then a private room, and then respite care is a lower cost, but over time. Yeah. And so again, these expenses cover non-care staff, utilities, mortgages, building maintenance, and major capital repairs. So on to who works in and with long-term care. So who works in long-term care? We have a centerpiece here of, you'll see who the middle person is, and I'm sure you can guess. But we have physiotherapists, we have nurses, so registered nurses, registered practical nurses, and nurse practitioners. There's personal support workers, or sometimes they're called personal care aides, which are the individuals that are typically providing the hands-on care with activities of daily living and hygiene and that sort of stuff. There's housekeeping staff, food service workers, so that's the dietary staff and the cooks and working in the serveries, providing the food for the residents. Social workers, they might help arrange for appointments. They often help bridge gaps with, say, financing, with financial situations, and they're kind of our go-to person outside of the nursing realm of things. Resident service workers, which includes a lot of different individuals. So there's hairdresser, volunteers. These volunteers are running a tuck shop, so they can, the residents can buy stuff down like in the facility, and they can go and like a little kind of convenience store sort of thing. There's recreation service workers that organize programs for the residents, spiritual services, computer and technology, people providing that for the residents to use, and especially right now in this time during COVID, it's been super important because it's allowed families to connect with their loved ones in long-term care and see them face-to-face over video calls. There's art and music therapists. We have behavioral support. So this is a team that helps with residents that have maybe more psychological diagnoses and reaching out to psychiatry supports outside of the facility. There's infection prevention and control team, which of course now during COVID is in full gear and really helping protect our residents and our staff. We have physicians, of course, occupational therapists. They work alongside as well with the physiotherapist, ensuring that the residents are safe, and they might implement like the protocols for, say, after a fall, of having a falls mat in place, a bed alarm, or making sure that they have proper fitting wheelchair, that sort of stuff. And of course, building maintenance staff are a big part of the home too. When there's a leaky faucet, we have to call somebody, and they're making sure that everything is staying up to safety standards. And as I mentioned, the most important person in the home are the residents, and that's who we're all working to care for. And they are the center of the home. There's no doubt about that. And so who works with long-term care? So not everything can be done in-house, and we have to reach out to different resources outside of the home. So for instance, labs, so for blood work or other kind of specimen collection, imaging, so x-rays or ultrasound technicians might come into the home. It kind of saves a trip of having to go to the hospital. They can come into the home and do that. Speech and language pathologists, they'll often do eating assessments for the residents to see maybe what texture of diet is safe for the resident. There's a hospital outreach team, which unfortunately during COVID, they're not really, haven't come in, at least not at my home, but they would be there if, say, one of our residents had an IV hooked up, they would come in and take care of that, or they'd follow up with recent hospital admissions. Oxygen supply, so some residents might need supplemental oxygen, and oxygen concentrators need to be refilled, so we have reached out for that. Podiatry, providing foot care for the residents. Dentistry, of course, providing oral care. Laundry services, so we do have laundry within most facilities, but then it is a lot when you consider bed linens and personal items. So often I think most homes send out bed linens and have that laundered outside of the facility. And of course, the local health integration network, which is that agency that helps place people and manage wait lists within long-term care. So they are a big resource and connection to long-term care. Onto within the home again, so the organizational structure within a home, it can, maybe titles might vary a little bit here and there, but there is, again, in Long-Term Care Act, it is very clearly identified as to what is mandatory to have in a home. So all homes must have an administrator who is responsible for the home's management. This individual does not require a nursing education. They sometimes have a nursing education, but that's not a requirement. And there's also often an assistant administrator as well. There's a director of nursing care, or a director of nursing or director of care. Depending on the size of the home, they might title it something different, one or the other. And they supervise and direct nursing and personal care staff. And this person must be a registered nurse and have an educational background in nursing, which makes sense because they are directly supervising that care. So there's medical director, so a physician who is advising on matters relating to medical care in the home. And often this medical director, the physician, will also be one of the attending physicians in the home. And then there's managers, so all sorts of managers. There's building service managers, resident services manager, food and nutrition manager, nursing manager, and those managers hire, manage, and monitor the frontline staff. And then of course the frontline staff, so nurses, PSWs, like cooks and cleaners, and everyone and anyone that you can think of that's on that front line, and kind of the face of the home and providing care to the residents, whether directly or indirectly. Okay, so on to a day in the life. So as I said, this is just my experience in long-term care of what a typical day looks like. Of course, that can vary depending on the person, depending on the facility, depending on your role as a nurse in long-term care. And of course, I can't even go into detail of everything that might happen in a day, but this is just kind of a general overview for you to see what it looks like from start to finish on a typical day. And I know for myself, I typically work a day shift, so from 7 in the morning till 3 in the afternoon. And I start off by arriving at work on time, or of course even early. And now we have to do a COVID screening, which includes a survey on your phone. So there's a built-in kind of application that you do a questionnaire for COVID screening. You get a temperature check done, and rapid testing is now in place at homes, which is done every other shift or every other day. You go up to your unit, wherever that may be, and for registered staff, again, depending on your role, you'd review the staff roster. This may indicate that you might be short-staffed that day, and you might have to reach out to staff and see if anyone is able to come in last minute to work. And it's also just a good review to see who's on and how you're going to assign the staff into their roles. And so that leads over to the next of assigning staff to their roles. So as a registered staff, again, depending on your role on our unit, typically the RN does this, but if there is no RN on the floor, staff have to be allocated to their assignment. So full-time staff typically, maintain their assignment of which residents they're caring for. And then this is in the case of PSWs or PCAs, and part-time staff then kind of switch roles depending on what full-time staff were there, and to fill the gaps in care. And something that is always considered is continuity of care, because it is, like I said, always for the residents, and it's nice for them to have a familiar face. And if a part-time staff was there yesterday and they're here again today, then we want them to be in that same position so that there's more fluidity in the day, and it's more smooth sailing kind of, and comfort for the resident as well. And then as a team, we read report. So we go through the last 2 shifts. So on a day shift, we would read report from what happened overnight, as well as what happened the previous evening. After reading report, you go and you prepare your cart. So whether you're providing, administering medication or treatment, you make sure that all your supplies are in place and you're all ready to make your way onto the unit. This might include going and collecting cups from the servery, or filling your jug with water, getting some applesauce for crushed medications, and making sure that your treatment cart is stocked with your normal saline and gauze, and everything's in there ready for you to go onto the unit. So you don't have to be pacing back and forth to the supply room. You want to be as efficient as possible. And typically, depending on the shift, this is more so for evening shift, but you want to review any major changes to orders. If they haven't fully been processed yet, that's something that needs to be done before you make your way onto the unit. And again, you collect supplies. So it's not only supplies for nurses, but also for the PSWs. So collecting the briefs, and they might need garbage bags, or and that's all kind of stored and locked up. So collect that for them. And then you go onto the unit and you start your medication pass or your treatment pass, and you work your way through and providing medication to all the residents. Afterwards, take a break. You deserved it.
you should go take a break. You know, of course, you might have to do a little bit of follow-up. There is most of the time, some flexibility in this of what you do when after medication pass. Those are allocated times that the residents need to receive their medication. But as for taking a break, depending on the team that you're working with, you know, you have to just make sure that it's safe and that there is somebody on the unit. And then you have your break and you come back, and then there's more orders most likely to be processed. There might be follow-ups, whether that's follow-ups from family members, follow-ups from the interprofessional team. So maybe physiotherapy has made some new recommendations, or occupational therapists new recommendations. You have to follow those up. Like I said, contacting family, or maybe the resident expressed some sort of concern. You have to look into past documentation, all of those sort of things. You kind of do in between your passes, and any sort of referrals that might need to be made. So whether that is a referral to a speech language pathologist, because you notice that during breakfast time, the resident was having difficulty swallowing this texture, or they were spitting it out, and you think maybe they might need to be have a change in texture. So you need to have that assessed, and you'll refer to the speech language pathologist for that. And then before you know it, it's lunchtime or nearly lunchtime, and the next medication pass is here, and you make your way back onto the unit again. And then after that's done, more follow-ups, and another break, hopefully, if you have time. You should have time. And then when you're leaving, you go and you have to do exit screening for COVID again, and you head on home. And like I said, this is a very brief overview of what a day looks like. It sounds so nice, even for myself reading it, because you can bet that most days don't go so smoothly. And that's okay. That's fine. That's part of nursing. And that's why I love it. But yeah, a day can include a new admission, or you might have to send someone out to hospital to get further assessment done. You might, there might be some sort of incident of some sort, a fall, and then there's lots of documentation required after that. And throughout your whole day, something that is super, super important, and it's not emphasized enough, or it is probably emphasized enough, but document, document, document. Everything needs to be documented, and it's so important because, as we say, that if it's not documented, it did not happen. So we need to make sure we do that. So you kind of get an idea through a day in the life of what the responsibilities are of a registered staff, but I've kind of highlighted a few things that maybe weren't touched on in that day of life. So every shift, you're going to be doing either a medication round or a treatment administration, maybe processing some new orders. Now with COVID, there's COVID screening for the residents also every day, twice a day. So they'll have a temperature check, and there's an assessment tool as well for that, for COVID screening for any symptoms relating to COVID. And then, like I said, following up with family inquiries. At the start and end of every shift, there's a narcotic count for the narcotics with 2 registered staff that needs to be done. On a weekly basis, we receive medication strips for the resident that has all their medications for the week. So those have to be received and processed, and ordering supplies for the unit. So like it says here, some gauze, normal saline, syringes, straws, body wash, anything that might be needed on the unit. We need to kind of keep an eye on and track what's running low so that we don't run out. On a monthly basis, we take vital signs for all the residents. Some residents, of course, get vital signs taken way more frequently depending on their conditions, and some orders have it that it's 3 times a week, especially when there's medication changes. Monthly, there's medication reviews with the prescriber. We have to calibrate blood glucose monitoring devices, as well as doing RAI and MDS coding, which I will touch on a little bit more as to what that is, but that helps us with our care plans for the residents to make sure they're getting proper care. And then I put PRN, so as needed, referrals to interprofessional team, calling the prescriber, MD, or the nurse practitioner for stat orders, attending care conferences with the team, the resident and family, transferring residents to hospital for further medical investigation, or updating residents' care plan. And like I said, that's it's a highlight. There's lots of things that can happen, even following up on bowel protocol, following up on PRN medications that were given, inquiring with appointments, connecting residents with their family members, and again, documentation, big important part. So what does a typical shift for nursing staff in long-term care? They're typically 8-hour shifts. So from 7 to 1500 or 3 p.m. is considered a day shift. From 3 p.m. till 11 p.m. is considered an evening shift. And from 11 p.m. till 7 a.m. considered a night shift. Of course, these hours can kind of maybe vary. I know that some places do at the half hour rather than the hour. So it'd be from 7:30 to 3:30. But you get the idea, 8-hour shifts, 3 shifts in a day. It is 24-hour care. And that's how we do it in those three different shifts. And typically you have 2 30-minute breaks. One is paid, one is unpaid. And as for full-time, part-time, a lot of nurses start part-time, and depending on the need for staffing, you might work, anywhere from 2 to full-time hours, 2 shifts to 5 shifts a week. And this is a permanent position, or maybe it might be temporary, like I said, depending on the need of the facility. That can really vary. So what is it like working in long-term care? So some of the challenges of working in long-term care are the large resident load. So, as I had mentioned earlier, I had the opportunity to speak with some clients of care and that have worked in long-term care. And I asked them this question of what's it like working in long-term care? And one person, Amandeep, said working with dementia patients was hard to understand in the beginning what they were trying to say. And especially indicating those, behaviors that are causing them to want to exit seek. She says that was a very challenging part for her at the beginning. Livia mentioned lack of staff, which we'll leave it with that tip of the iceberg, because that is definitely a point of contention right now within long-term care. And we are really hoping and fighting for more staffing, because the residents deserve more time and more care. So I think everybody in long-term care can totally relate to lack of staff. I mean, nursing profession as a whole can be challenging with that. And Livia also mentioned there's a lot of documentation with long-term care being so heavily regulated. We have to make sure to document appropriately and where we need to document. So that might be putting the same thing in multiple assessment tools, or just to make sure that this documentation is there and it's present and it's seen. And it, like I have here mentioned, so large resident load, overseeing unregulated care providers. So that would be the personal support workers and personal care, or personal care aides, as they're sometimes called. They are your eyes in the long-term care home. They are providing that intimate care with the residents, and you as a registered staff really rely on them. And so it's so important. I can't emphasize it enough, of building relationships with the PSWs, because without them, a lot of things would not happen, and a lot of things would go missed. And so taking the opportunity to build those relationships is like truly important. And it can be challenging at times, because there's 40 residents, there's each of these PSWs might have 10 residents to care for, and then you're overseeing them and the residents. It can be a lot in a day, and that can be very challenging. You're working with different personalities, and you just have to remind yourself and remind your team that why you're all there, and that you're all there for the residents. Also some challenges is family expectations of that, you know, especially families that did have their loved ones at home and that they were caring for them, but then it just became too much. They have high expectations for their loved ones and how they should be cared. And I think they should. They absolutely should. Of course, every one of us would want our parents, our loved ones to be cared for in the best possible way. And so that is challenging, but it's a totally understandable aspect of long-term care. And losing residents, some are at the end of their life, and you get to build a bond with them and you get to build that connection, which is such a lovely and one of the best parts of, I think, working in long-term care. But then it comes with the heaviness of losing a resident, and yeah, that's part of working in long-term care. But it's good to know that you were there at the end and you provided them with that support at the end, and you did the best to make their last weeks, months, days positive and comfortable. And that's all you can really do as a healthcare provider. So why work in long-term care? So as I mentioned, building those connections with the residents, it can be so rewarding just to brighten someone's day. I think one of my favorite things is I do like to make jokes, and so when I go in and I can make a resident laugh, it's like my day is complete. I'm so happy to go home and just to think to myself that I cheered them up and smiled, especially when they're not having a great day, because you really get to know the residents. You are their family. You're there every day, or 5 days a week, maybe for full time, and you're building that connection, and they know you, and it's so important to be there for them and do your best. And also you get so many great leadership opportunities. So you can help, educate fellow nurses. You can, educate student nurses. There's so many things you can do with that. And being able to work with the interdisciplinary team of working with the physiotherapists, occupational therapists, physicians, we all really rely on each other because we all have our specialties, and it's important to keep that communication open and collaborate to have the best care possible for the residents. And also working in long-term care, the reality is we have an aging population, and there's a need. There is a real need, and we need more people in long-term care. We need interested nurses to work there, because to get those hours that residents need for care, it's really important. And so I have actually from a statistic of that, dementia cases in Canada is expected to increase by 66% up into 2031. And considering that in long-term care, 2 out of 3 residents have dementia, that kind of just goes to show that there is going to be just a big growth of residents coming into long-term care. So there's that need. Back into speaking to some of the clients of care, when I did my podcast episode, Amanda mentioned what she liked about working in long-term care was having interaction with the seniors. In her culture, it is very important to respect seniors. And so for her, building those bonds and interacting with them was very important. Livia, also another client of care, had mentioned you get to give them comfort, and you are actually their family. You give them support in their last days of their life, and that's what gives her the feeling that she's accomplished what she wanted to in nursing, which I think is lovely. And it's true. I think as nurses, we want to be there for people, and we want to support them and give comfort. Really, that's a big part of nursing. Okay, so leading into near the end here, what are some future opportunities that can lead from working in long-term care? So as I touched on, leadership roles, so mentoring other nurses, nursing students, behavioral support leads. So within a home, there's a team of nurses that focus on connecting residents with psychiatric help outside of the home to support them in their care. There is infection prevention and control lead, which prevent or reduce the risk of transmission of microorganisms. So as a nurse, that could be something if you're interested in. Nurse manager, so going into a more managerial position. There's RI MDS coordinator. So RI is a resident assessment instrument, and MDS is a minimum data set. And so what the coordinator does, or what this RI MDS assessment tool is for, is to collect the minimum amount of data to guide care planning and monitoring for residents in long-term care. So it's a very, very, very important part of ensuring that residents are getting the care that they need. And that is also a good way to think of it, is that we're being recognized for the care that we're providing as well. Also within a home, you might have nurse educator, wound care lead. So I think those are both quite self-explanatory, but they can go around and support the units in specialties of wound care and how to improve wounds on the unit, and just an additional support within the home. And then even outside of that, there's many continuing education programs where you can have a geriatric focus. So working in long-term care doesn't mean just giving medications to 40 residents or providing treatment. There is a lot more beyond that. And it is, as I've mentioned, a very rewarding area of nursing. And I'm very privileged to be able to start my career, and hopefully I'll continue my career in this area. And so that is all from me. Is there any questions? Let's see in the chat. Okay.
Yeah, that's a question. Yeah, I have a question.
Sure. Yeah.
During COVID-19, do you invite a person with a dog, like golden retriever, for example?
Sorry, so do we have like dogs visiting?
Yeah.
In my home, we have not. In the past, that's definitely one of the having therapy dogs come in. But in my home, that hasn't happened yet. But I foresee that might be happening in the future, because we're slowly now allowing visitors, with more people being vaccinated, because it's for safety reasons, of course, of minimizing the risk of transmission of COVID-19, and so minimizing the amount of people coming into the home. But yeah, therapy dogs are definitely something that I think the residents love, and that definitely cheers them up. So I hope that it can come back again to the home soon.
Okay. There's another question. Do you invite like ostomy therapies, for example, if person has stoma?
That's kind of something that, at least in my home, that you can reach out to the hospital outreach team for that. And there's definitely many resources in the community and specialties that you can reach out for. As I mentioned, we haven't dealt with that in my home, but I know that those resources do exist, and yeah, within the community.
Okay, another question. Like, if a person passed away, what kind of documentation do you need to register?
So if a person passes away? Yeah. Okay. So that is a multifaceted question. So when a person passes away, you do need to have a pronouncement by a physician. And so there has to be a death certificate, and that is like processed by the physician actually. And then of course you document as a nurse what you witnessed, it, like how you approached the situation, what steps you took. And it also depends on the situation of what code status that resident was. So even though in long-term care there are older residents, some residents are full code. And so depending on that situation, it varies. But are you interested in seeing like a full detail of a rundown of how things happen, or what's kind of your interest?
I mean, like, for example, if you work on night shift, there is no physician at the moment, you know, like how would you?
Oh, so yeah, so there's an on-call physician. Absolutely.
Oh, okay.
Yeah. So there's always going to be, you always have to have some sort of MD like available to be contacted. So for us, like on our unit, from 8 a.m. to 8 p.m., we call our attending physician. And then
on night shift, like so from evening into night, so from 8 p.m. to 8 a.m. the next day, there is always an on-call physician that you would contact in that situation. Yeah, it's not expected that the nursing staff deal with that on their own.
Vanessa, there are several questions in the chat box that you might want to have a look at.
Sure. Okay. Thank you, Diane. In your facility, what is the RN staff patient ratio and the PSW patient ratio? And in your opinion, is it adequate to meet the needs as described of residents, and the skill mix? Is the skill mix correct? Okay, so for instance, I'll give you my example of on my unit, on the unit that I work on day shift, we have at full capacity, we have 79 beds, and we have 8 PSWs, so give or take 1 PSW for 10 residents. And then we have 2 RPNs. So actually something good to explain is that our unit is split kind of into 2 pods. So there's 2 RPNs on one pod, 2 RPNs on the other pod, and then an RN kind of in the middle overseeing both sides. Do I think that this is adequate to meet the needs? No, because I think that residents do deserve more time and more care, and 1 to 10 for direct care is very challenging. So I will absolutely say that we need more staff for the residents. No questions asked about that. And is the skill mix correct? Absolutely. I think that we have such a great, I can only speak again from my experience of that we have nurses that have worked in all areas of nursing. Before COVID, a lot of our staff worked in multiple facilities. Obviously that is not allowed currently. But yeah, there's a mix of background of experience, and especially for myself, I'm 2 years in now, but as a new nurse, it's really helpful to have mentors on your team that have years and years, decades of experience. You know, some of the staff are, you know, edging closer to retirement and have decades and decades of experience to help you. So I think the skill mix is great. And I don't know if you also meant the skill mix of PSWs to nursing staff, but yeah, I think that's also an important thing to consider for sure. Okay, next question. To what extent of autonomy do RNs in long-term care have over those who are in hospitals? To what extent of autonomy? Well, like I said, there, you know, long-term care is very regulated. So there is very strict protocols and procedures that we do have to follow. In theory, I guess as an RN, if you're on a fully staffed unit, for instance, on the unit as I was speaking, that when they're in the middle, they do have more flexibility and autonomy in that sense. But there is also very strict rules and guidelines that they're having to follow and make sure that expectations are met and that we are following the Long-Term Care Act and providing the best care possible. So there is a lot of responsibility, of course, that comes with being an RN in long-term care, because you are overseeing RPNs, you're overseeing PSWs, and there is maybe 80 residents that you're having to oversee as well. But there could be a little bit of flexibility in the schedule for sure. Okay, next question. Ella, excellent presentation. Thank you, Ella. In addition to the questions above, what is the, let me move this over here. What is the ratio of full-time to part-time casual staff? So that's actually something that is, I know I work for a publicly funded home, like a public home, municipal home, and that is an area that is been brought up many times because it is, I think the ratio at this point, off the top of my head here, is 60% or even maybe 70% part-time and 30 to 40% full-time, which makes it very challenging. Of course, right now it's kind of been put a little bit on the back burner with COVID, but prior to COVID, as I mentioned, a lot of staff, because they are only able to pick up part-time or casual positions, they're having to work in multiple places, which of course we know can lead to burnout And that just exacerbates the whole issue of providing quality care. So there's definitely a shift that needs to happen with the ratio of full-time to part-time staff for sure.
And by any reason, for if you have shortage of staff, you call for agency for assistance, you invite some nurses from agency?
Some homes will do that. I know because in the public sector, I know that I think within COVID was the first time that they reached out to agency, from what I understand. But yeah, many privately owned homes will reach out to agencies to help fill that gap. But of course, we try to work from within first of, you know, pulling from another floor, because maybe another floor has a lower patient ratio and you can pull a staff, but it really depends. It's not such a simple answer, but it depends on the shift, depends on the ratios, and we just have to do what's best with staffing and to provide the safest care. How much is the starting salary of an RPN and RN working in long-term care? You can definitely see, depending on location. I know that with public sector, RPNs are starting at about $31 an hour, and RNs start at about $36 or maybe $38 an hour, versus in the private sector, it is about $4 or $5 less per hour for each at a starting rate. Ella, okay. So as a nurse, what are your thoughts on what went wrong in long-term care in the early days of COVID? That's a tough one to answer. And I don't know if I have a really great logical answer for that. I think it's so complicated, so multifaceted. Honestly, it's even silly for me to say this, but maybe like luck came into play in some places. Like I work in a large home. Knock on wood, we've been very fortunate to not have many cases. And I think we weren't prepared, is what it comes down to. And we maybe didn't take it seriously enough, but that could be a topic for discussion.
Thank you. I didn't want to put you on the spot, but I was welcoming your thoughts. Thank you. Thanks.
Thanks, Ella. Yeah, I know it's very complicated. Okay, Penny, what role does an NP play in long-term care home, and what would the starting salary be? That's a good question. So actually in the long-term care home that I work at, we have one practicing nurse practitioner, and she kind of is the main full-time prescriber in the home. So she's there most days, like Monday to Friday, kind of similar hours to the RPNs and RNs, maybe more like 8 to 4. So she has a little overlap on days and evening shift. And like I said, yeah, so she's the main kind of prescriber for the home. As I mentioned before, there is often attending physicians for each floor, but they're only come to the home maybe 1 or 2 days a week. And so the nurse practitioner is often there Monday to Friday and also on some weekends. So she plays a big role, very big role in the home and as a resource to have. Absolutely. As a starting salary for a nurse practitioner, I can't say that I actually know. I can absolutely look that up and get back to you if you'd like, Penny, if that's something you really want to know.
Thank you.
So Natasha, an RN who's been working for years in long-term care, adapt easily in a hospital facility. I think that if you get hired, the leadership opportunities that you got in long-term care, you can't even compare that. I think that there's such a great skill set that you build in long-term care. And I think what it comes down to is the facility where you get hired in a hospital and that they provide you with the proper training. I think that at the end of the day, that's a big part of getting properly trained and being able to adapt to that new place.
And so I don't think that there's any reason why a nurse shouldn't be able to transition from long-term care into a more acute setting, and vice versa. You just need to have a good team that supports each other, and that goes a long way. Vincent, where are we now in flight for better staff resident ratio? Have you ever worked in an understaffed shift? How severe was it? Yeah, this is a better staff ratio. So I think, like I said, of course, right now, COVID and really brought attention to long-term care. And I think, I mean, it's something that's been on the radar for decades, and it just gets brought up, and then it gets swept under the rug and brought up and swept under the rug from what I've read. And but COVID really brought attention to some of the living situations and the staffing ratios in long-term care. So I think that you need public attention for something like this and for change to happen. So I think I hope that this leads to a better outcome and better staff ratios. And have I ever worked on an understaffed shift? Absolutely. Fortunately, it was not very severe. You just have to be, fortunately, you know, it was a group of experienced nurses and staff, and we were able to be flexible and work and still provide safe care. And I understand that there's been a lot of situations where that's not the case, as we've seen in the news and media, and yeah, I can't really speak to that.
Excuse me, Vanessa?
Yeah.
Yeah, in your current staffing plan now in your long-term care,
Yeah.
how many patients do you handle as an RPN?
So on a day shift, there's 40 residents, and then, but there's me and like a co-RPN. So one of us will be doing medication and one of us will be doing treatment.
Okay,
And then, so 40 residents on one side, and then on evening shift, you're the sole nurse on that. So you're 40 residents to one registered staff, and then you have your PSW complement as well in there.
Okay, so in your experience handling 48 patients, do you think you can use 48 residents? Do you think you can deliver safe care to those residents? And if not, what the ratio of an RPN to resident do you suggest that we apply to our long-term care homes? Based on your experience.
Yeah, so it's sorry, just to clarify, it's 40 residents, not 48. But and so I think a big aspect is the care and like ADLs, and so that role is for PSWs mostly. I mean, on night shift, there's definitely, at my facility, there's definitely registered staff also providing care, and of course I step in all the time as well during the shift, and I want to step in as much as possible because that's how you really get to see the residents and know the residents. But I think that it's not up to me to decide of say what the ratio should be, because it really depends on the needs of the resident. Of course, some residents are more independent than others, and a 1 to 10 ratio can work, but that's not, of course, not the case for most of long-term care. So it really, that's why we do these kind of like RI MDS assessments for residents, is to see a big part of it is funding as well, of how much funding we need, and that funding goes into staffing. But I don't want to say really a number of what the ratio should be, because I don't think that there's a clear-cut answer. But what we can say is that there does need to be more staff, and that needs to be addressed, whether that's increasing the number of PSWs, increasing the number of registered staff. The needs are different from home to home, from floor, from unit to unit. So but we just need to find a way to increase those hours that the residents get care.
Like, for example, if you will be asked, which category of staff do we need to add? RPN or more PSW, if you're going to choose one, based on your current experience now? Yeah,
if I had to choose in my current home, this is maybe not the case in every home, I would honestly say, oh, that's tough. I would say PSW.
Okay.
That's in my opinion, in my current home, but I know that's 100% not the case. And on some shifts, I might say
RPNs, because it really depends. But like, it's just the whole complement has to adjust and improve and change. It's not, yeah. Sorry that I can't give you like more details. Really, to me, it's not like a clear, clean-cut answer of saying we need this exact number of staff, because it really, to me, depends on the home, depending on the needs of the residents. So I don't know if anyone else wants to weigh in. Ruth, if you have anything to say about that.
Okay.
No, I wasn't going to make a comment on that. I was just going to really thank everybody for how well they have given questions and participated in the discussion. It's really been very fruitful. And I wanted to thank Vanessa for her presentation, which has really helped many of us more completely understand some of the challenges and the really rewards of working in a long-term care facility. Also, for those of you perhaps who still have questions, please feel free to forward them, and Vanessa, I'm sure, we'll forward them on to her, and we'll be happy to get back to you. But again, thank you so much, Vanessa. I think this has really been very enlightening, and we wish you all the best in your career in long-term care. I personally believe that there are lots of wonderful opportunities in long-term care for nursing development. So again, I want to thank you very much for this presentation.
Thank you. Just one last quick little thing. I do have a little survey that I would love for all of you to fill out for feedback. I'm just going to pop it into the chat here. It's through Google Forms. Oh, I'm having a technical issue here. Why? Hold on. And also I wanted to, as I mentioned at the beginning, provide the link for the podcast that I recorded with some of the lovely clients of care that shared their awesome experience of working in long-term care. Oh, that's not working. It appears that my link did not post as a link. Well, you can go through the care website, and the link is there for the podcast if you're interested in listening to the podcast. And yes, thank you everyone very much for your participation.
Ruth, you want to share the next upcoming Nursing Week presentation? So I also like to thank Vanessa very, very much. Great job, Vanessa. Actually, when I look at someone like you, I see so much hope in nursing. This is coming from my own nurse myself, right? So it just got me so excited to see our next generation of nursing leaders and all the interest that raised at this webinar, and a lot of good questions. So best wishes in your nursing journey. And as an OD, I'm here to help you in any way you think that I can be useful to you. So please do keep in touch. I'm sure we will be talking to each other before you graduate and move on, but please keep in touch. And thank you so much for taking an interest in Care Center for International Educated Nurses, and a special interest in supporting IENs as well.
Thank you for giving me the opportunity.
Yeah. Ruth, off to you for next.
Ruth, I'm going to ask you to tell everybody about the next exciting webinar that we have as part of our celebration.
Yeah, so I'm absolutely delighted. We're very fortunate to have Dr. Angela Cooper-Broadway, the immediate past president of the Registered Nurses Association of Ontario, doing our Nursing Week as well as 20th anniversary webinar on racism against Black nurses and nursing students. And of course, looking into ways that how we can make things better for everyone. Not tolerate any kind of unprofessional behavior and so on. So Angela come with a lot of experience, and she have a lot to share as well, particularly in community health too. So just a little forecast, and you will be receiving that invitation to our next webinar, as I mentioned, for Nursing Week. And we average to have one webinar every month for the whole celebration year of our 20th anniversary, except August, because I think everybody deserves a little break in the summer. So best wishes to all. And thank you, Ruth, for sharing this.